presentation rounds. Next slide, please. Our team of organizers, of course, this is something that it takes a team effort in order to do. I am so grateful to work alongside this amazing group. The team of organizers, from for today are the Virginia Department of Health, Janae Oliver. Within the American Cancer Society, Annika Dean, myself, Juanita Thompson, Jan Bennett, and our Senior Director, Regay King. Virginia Health Catalyst, Erica Fassetti. And then we also have a number of organizations in which we do partner, and we are so grateful for that. And of course, UVA Cancer Center, Secours School of Nursing, INOVA, VCU Massey Cancer Center, Carilion, Virginia Department of Health, CACV, which is our parent organization, and of course, VHIT. Next slide, please. So here is our mission for the VHIT organization. It's to assemble all stakeholders, united partners promoting and supporting HPV prevention with a focus on increasing adolescent vaccination rates through an evidence-based approach. There are 40 plus organizations that are represented in VHIT and constantly growing. If you are not a part of VHIT, please let us know and we will be glad to have you represent your organization on our task force. We have a priority subcommittee of the Cancer Action Coalition of Virginia, and we have a number of committees, including our providers and systems, school health, and a new arm that will be developed this year, 2021. Next slide. So as we talked about, today is the first of many when it comes to our provider education series. Of course, January to June, we will not have one in July because we do meet every first Wednesday of the month, and that's a little too close to holiday. But we will reconvene for our final series in August. But we're asking you right now. So again, I ask of you in the chat to please let us know, what more do you want to learn about HPV? We are grateful that Dr. Tuohy will be talking to us today from a pediatrics perspective, but we would also like to hear from you. You can also register for peer-to-peer events as well. So please feel free to share with us. Next slide, please. And as you all are chatting, are placing your information and questions into the chat, I have the pleasure of introducing you all to Dr. Tuohy, who attended the University of Notre Dame for her undergraduate degree. She received her medical degree from Medical College of Georgia and completed her pediatric residency at University of Utah Department of Pediatrics. She has over 20 years of general pediatric experience, having practiced in Minnesota, Georgia, and Virginia. Dr. Tuohy is also board certified by the American Academy of Pediatrics. She currently resides, She currently resides as the Regional Medical Director for Pediatrics for Bon Secours Mercy in the Richmond market and is a full-time pediatrician practicing at the Mechanicsville location. Very happy to have you today. Next slide, please. So now it's time for us to do a pulse check. This is where we are going to ask information and again want you to utilize that chat box for your answers. So the very first question is, true or false? Adolescent HPV initiation rates have been increasing since 2016. You can just simply write true or false. I guarantee you this is not a trick question. Great, great. See answers coming in. Wonderful. All right, second question, and we will go over these at the end. Name a type of contraindication associated with vaccinations. And third question, how many types of cancer are prevented by the HPV vaccine? Wonderful, wonderful. I see responses coming through. We, of course, will have this information confirmed by our subject matter expert, Dr. Tuohy, after her presentation. So you'll have to hold on. We're in suspense. Next slide, please. And without further ado, I am very grateful once again to have our speaker take the floor, and we are very excited to hear your presentation. Dr. Tuohy, it's now the floor is yours.
Thank you, Juanita. I hope you guys can hear me well enough. I apologize for my tardy arrival here.
No problem.
But Happy New Year to everyone, and thanks for starting off the new year. Hopefully you're on a good foot, just remembering about HPV, and we'll kind of talk about what things that we can do as providers to help to increase that immunization rate, as we were discussing just there with those first few questions. So as he mentioned, I serve as Regional Medical Director for Pediatrics within our Secours group here in the Richmond area. And there are 5 offices that are pediatric based, and about 12 practitioners who work throughout the area. So you know, we try to be all on the same page and to be working for the benefit of our children. Next slide. So I have nothing to disclose, no conflict of interest, nothing in particular associated with Merck. I have no ties to them. So I just want to introduce HPV and give a little background as to what the actual virus itself is. It is a small DNA virus that has over 200 types that have currently been identified. There certainly can be more, as we know, as we gain more knowledge across the field, but there are 200 types, and several of these types are very virulent and can cause disease. Most types, though, infect the cutaneous epithelium and cause maybe just regular common warts, which I also treat in the office, and I'm sure many of you guys do too. But that is actually a type of HPV. It's not an aggressive type. However, especially in the pediatric population, though we adults can get these as well, we see them quite frequently. So 40 different types infect the mucosal epithelium, and those are the ones we're focused on. There are often no signs or symptoms of the infection being present. So anyone who has the virus can easily pass it along without even knowing it. But it is very common in the United States. So an estimated 79 million people are infected with HPV in the United States. Most, as I just mentioned before, it clears. But for those who don't clear, the virus can cause perhaps certain cancers and other diseases. Because it is unknown which patients will be more susceptible to the more severe components of this virus, it's important to think about immunization when we have that available, because we really, bottom line is, we want to prevent cancer. So as far as in the United States, genital HPV is the most common sexually transmitted infection. It is common and most prevalent in the early adolescent and young adult age range. This just kind of repeats a few of the other things, but within 10 years of having had our initial quadrivalent GARDASIL introduced, which was in 2006, within 10 years of introducing that, HPV types included there 6, 11, 16, and 18 had decreased 86% among females at the younger age and 71% amongst females at the a little bit older range. Now that we have the 9-valent GARDASIL, it has currently been in use since 2014, and we've added a few more serotypes for more protection. So I know a lot of this is a little reiterating, but just to kind of demonstrate also that the high risk types of those 16, 18, and now we added 31, 33, 45, 52, 58 to the GARDASIL 9. The lower risk types, though still included in that original HP, or the GARDASIL, which was the quadrivalent vaccine, were 6 and 11. So those have a little bit more low grade, but still can cause these warts, especially the papillomatosis that we even see in pediatrics after children have been born to moms who've had HPV infection at the time of delivery, particularly vaginal delivery. But other things that you can see that are not quite as aggressive with other much lower risk types of the HPV are these other skin warts. So the CDC recommends routine HPV vaccine at age 11 or 12 for both males and females. It can be given as early as age 9, though I would say that is not routine practice. The routine practice in our pediatric world is really 11 or 12. And it can be utilized as catch-up vaccine as well in older folks, and even all the way up to 45, based on how those older adults, I mean, they're not that old, they're only 27 years old, that's still pretty young. If they hadn't received it beforehand, they could add that into their vaccine repertoire after speaking with their physician when they're older. So the AAP and the ACIP also have similar recommendations. I will say for the 9 to 14 years of age, it is currently a 2-dose series separated by 6 months at a minimum, and up to 12 months. We do not, however, repeat that vaccine if it has been longer than 12 months. That is, we don't repeat the initial vaccine, we just complete that second dose if they have started between 9 and 14 years of age. After the GARDASIL initially came out, there were excellent follow-up studies as to antibody levels, and the younger children, as we would expect with all sorts of our other vaccines, really accept and respond to this vaccine very energetically, such that they can only be required to have 2 doses, versus as they get older and they're a little bit more resistant to accepting vaccine immunity, a 3-dose series is recommended. This was actually based on the similar platform as hepatitis B vaccine when it was first developed, on a 0, 2, and 6-month schedule. So you can just drop that 2-month visit or injection, pardon me, for the younger children. Catch-up vaccines are certainly always encouraged, and that's what I was kind of implying before. So if it has been more than 12 months, we are not repeating that dose. However, if it has been more than 12 months and the child is now much older adolescent, but they had received that dose earlier, usually we still are able to just do the 2-dose series. So what does this prevent? It prevents cervical, vulvar, vaginal, anal, oropharyngeal, and other head and neck cancers in females, and anal, oropharyngeal, and other head and neck cancers in males. And I've just listed kind of the different serotypes that we're trying to tackle here as well. The next slide, I think. So yeah, the next slide just demonstrates that as of this summer, there was a formal recommendation for HPV vaccine to be used in specifically to prevent head and neck cancer. So it had been felt that it was preventive, but it finally received the formal recommendation that it would be preventing this type of oropharyngeal cancer. Now, not all oropharyngeal cancers are caused by HPV. But certainly a good number are, and so if we can prevent those two in the process, that's what we're working toward. So then, contraindications to vaccines are a prior reaction to perhaps that original vaccine, an allergy to yeast or latex. So if there's any prior history of immediate hypersensitivity reaction to either one of these, that might be a reason to take pause. I will say for folks who've had latex allergy, typically we're just holding those patients and we're not it hasn't been a contraindication. Normal, that is greater than 10% of recipients. So more common local and systemic reactions can be seen in both boys and girls, including these listed. In girls, it was greater than 10% for them to be complaining of headaches. In boys, it was more like 6 to 7%. I think we'll see that on the next slide. But the big thing with HPV, though, is syncope. I do think a lot of this is a product of the population that we're immunizing. These are adolescents who may or may not be eating on a regular basis. And however, even if they have or have not eaten, we typically routinely will observe them for 15 minutes after at least their initial vaccination. If they're driving, we keep them in the office after every injection. If they're not and they did well with that first dose, then their parent or caregiver can bring them home, typically a little bit sooner. Sometimes, as we all know, with syncope, you can have some tonic-clonic type movements, which sometimes can be interpreted as a seizure, especially for those who have not experienced something like that or witnessed that. That would probably be a parent seeing their child do this, or caregiver. Typically, it is not a seizure. It is just the body's response to restoring that normal blood flow to the brain. Usually, just as a last precaution, if somebody's really sick, we would probably put the vaccine off, simply so that it's a little bit clearer picture if they have some type of side effect to the vaccine. Is it related to the vaccine? Is it related to the illness? If they have a little runny nose, but they're otherwise perfectly fine, that's not a contraindication to giving the vaccine on that day. So this just kind of puts out in graphic form some of those side effects. And it is pretty common that there is pain there at the injection site. I see that most all of these side effects are higher in girls than they are in boys. I wouldn't say, I don't have a great reason for that. I mean, certainly, like I mentioned before, headaches do happen in boys as well. It's just maybe girls complain about it more, or maybe it truly does happen with girls a little bit more, but just something to kind of think about. I will say, for most of my patients, if they are getting multiple vaccines on the same day, it's the GARDASIL that probably hurts the most going in, at least. It might not be as sore afterward, but going in, that's the one that they go, ooh. But, you know, it's not too much more than just that. So this is an amazing vaccine as far as vaccine efficacy goes. I don't have too many vaccines in my armamentarium that I can actually document that 98 to 99% of recipients receiving the antibody, have such an antibody response within the first month after completing the series, as it is recommended. So that's awesome. I mean, we want to get in the 90 percentile, but we don't ever really check antibody levels for most of our patients to be sure that they've gotten the proper antibody response. Those of us in the medical field, you know, we may have our hepatitis B titers checked, and of course we get our tetanus dosing every 10 years. That's not always the case, you know, with this, unless under study situations, but it is an amazingly great and effective vaccine. However, there are a few things, like if you have been exposed to HPV prior, it's not going to take that away. So it's not a treatment, it's a prevention. Anyway, so that's just kind of a caveat. But if you haven't seen these other serotypes that are included, it doesn't mean that you shouldn't still offer that to perhaps one of your patients to help prevent other serotypes that could still be very aggressive. So just speaking to some of those other questions that were part of the introduction, the HPV vaccination initiation rates has been increasing, especially among adolescents 13 to 17 years old. I will show you actually some von Secours data as well, but this is more national data that was obtained and does show, you know, both males and females increasing. Females still do have a little bit more receptivity, but those points are coming pretty darn close together by the last count in 2018. So I think that's really fantastic and a testament to, you know, getting the word out. As for completion rates, those are not quite as high. We want to be sure that if we've started the vaccine that we're able to complete it. So continuing to remind folks and things, and I'm going to talk a little bit more about some of those maneuvers that we can try just on a day-to-day basis as we are in our regular practice. So also, I just wanted to share some of our Bon Secours data since I have that personally in my back pocket. So we are not quite as good as the national average. We're trying to get there. This it does include family practice programs in addition to our pediatric program, but I would say it's primarily our pediatric patients that we're looking at. So as of last count, which was this past summer, we have a 44% completion rate for children by the age of 13, by the age of 13, which means we're counting the 2-dose series. I did not include data for just having completed the first dose. That is certainly higher, but this is really what we're trying to achieve is completion of the series, so that's what I focused on. 15% completion rate for patients who are 19 to 26. We definitely have a ways to go. This does include folks in the GYN practices as well, and so we're all trying to make a concerted effort to increase our completion rates. Though we have, since we started this study looking at what our completion rates have been, we have had incremental increases between 3 and 5% in each 6-month time frame. So though it doesn't look great now, it looks better than it did before, and we are still committed to doing better in the future. So there are definitely gaps in between HPV vaccination initiation and other adolescent vaccinations. My typical practice personally, and I think for many of my fellow pediatricians, is to present this vaccine with the other middle school vaccines. Today you'll be getting 3 vaccines. You'll be getting Tdap, meningitis, and HPV. They're all very important for your child entering middle school, or now that the requirement has gone to 7th grade. Anyway, as part of your middle school vaccines. There's still this gap, and so I'm going to kind of tackle a little bit of those reasons behind why there might be this gap. But certainly the Tdap has the highest. You can see a small decrease between Tdap and meningococcal, and then of course the HPV is lower. However, Tdap is mandated in this state, and I just want to draw attention that we're not at 100% Tdap immunization either. So I'll get also to that point a little bit later as for the other vaccines and where we are in the state of Virginia. So, oops. That's okay. So this is just, again, kind of to reiterate where we are. We are in the 60 to 69th percentile there by the light blue. Massachusetts has something going great because they're up to the 80 to 89th percentile, as does DC. But obviously other parts of the country are either on par or not doing quite as well as we are. So clearly still something to continue to have conversation about, like in forums like this. So I had to throw a little masked baby in there since we're all masking these days. But just as we protect our smallest patients by giving them their, newborn, infant, preschool vaccines, so too should we be protecting our middle schoolers, teens, and our young adults. So the Virginia Department of Health is working to improve vaccination rates along with the legislature as well. So in 2007, there was a recommendation after the Quadricel vaccine came out that 6th graders receive this vaccine, but they were still able to refuse. So then a couple years after the GARDASIL 9 came out, there's been formal letters to all parents of rising 6th graders to review this. I certainly received this as a parent of a rising middle schooler several times. And I was pleasantly, I was happy to receive it. So then last summer, House Bill 1090 came into effect, which essentially provides a stronger recommendation for all of the ACIP recommended vaccinations to be completed for school attendance. It still allows the opt-out option, but it's one more stronger recommendation for that to to occur. So it was a win in that respect because it got a lot of these, especially middle school vaccines, kind of back at the forefront for recognition. However, it still doesn't mandate for school attendance. The studies show that HPV recommendations that come from healthcare providers make the biggest difference in when parents or guardians of these patients are willing to accept or decline the HPV vaccine. I would say this holds true for most all vaccines, and that's part of a lot of what we do every day. So there are still some regional gaps as to how well we as providers are recommending the vaccinations, though, for our patients. And this demonstrates that we're in about the 79th percentile as far as provider having recommended to a patient to have the vaccine, whether they got it or not. Obviously, that number was a bit lower, but just to demonstrate that, you know, we should be greater than 90%, because when a patient comes to the office, we should be discussing this, not only ourselves as providers, but our staff, to kind of say, hey, it looks like you need this vaccine and that vaccine today. So Dr. Tuohy will talk to you about it when she comes in, but just kind of as a heads up. So it's a good approach to kind of incorporate for all vaccines, and perhaps as we move forward, even a COVID vaccine. But I'll leave that for a different day. So what can we do? We can certainly lead by example. We have a lot of posters and signs that talk about middle school vaccines, and it lists without any preferential order the vaccines, especially for middle schoolers in our kind of big kid rooms that exist. We at Secours are not able to have standing orders, but many other practices are able to do that, and that has been a big push from the AAP to have standing orders. So even if somebody comes in because they are getting their stitches removed and they might not even see a provider, they see a nurse, there's a standing order, you're due for your HPV, you're due for some other vaccine, we can talk about it and perhaps act on that. The other thing is really giving positive feedback. A lot of these parents and caregivers are reluctant and worried because there is so much chatter on social media and other online sources that is not reliable. And so they are kind of caught. They want to do what's best for their children, but are still reluctant to do that, which again brings our role into even a more powerful position. And so then educating with as much evidence as we possibly can. So for all healthcare providers, we are asked to, number one, assess the immunization status of all patients at each encounter. And I think, you know, in our busy days, sometimes we might not do that when we have some runny noses and things, but I think also readjusting our workflows in the world of COVID probably allows us to take a little step back and be able to have a little bit more time to be able to do that. To strongly recommend vaccines that the patients need, not just to assess, but then also to actually give them the vaccine when they're there, when that's not what they expected to get when they came, and then to document that so that they have record and that, of course, you keep record for them for the future. So as I mentioned before, kind of my approach is your child needs these 3 vaccines today, and then to also be confident in your recommendations. I just discussed side effects that we can see, certainly, and they are pretty mild. There are a lot of folks who are very worried about much more severe side effects. My daughter got HPV after she got the HPV vaccine. There's no way that she could have gotten it from the HPV vaccine. It is a killed vaccine. It is not a live vaccine. So kind of addressing some of those vaccine hesitancy items. I know that this is not easy. It is very time consuming. However, the payback in the end can be exponential, and it can be so protective, not only for the children themselves, but also for those that they come in contact with over the course of their lifetime. The biggest, I would say, hurdle for this vaccine in particular has been the misconception of promiscuity relating to the vaccine. My child is not sexually active. They do not need this vaccine right now. My child will never be sexually active. They do not need this vaccine right now. So kind of speaking to that in a frank and meaningful way, you're right. I'm happy and glad that your child is not sexually active at this point. However, we are social human beings, and I expect someday that they will be. And so recognizing that they do accept that immunity much better as they are younger. We want, as with all vaccines, to help prevent this infection prior to actually contracting it or coming in contact with it. So that's why it's so important to have completed that vaccine series before any of this happens, whether that's now or 10 years from now, whether it's 1 year from now or 10 years from now. So again, just this provider recommendation. Okay, now it took a while to get back to this slide. We'll go to the next slide. Thank you. It's okay. So motivational interviewing, this is the art of medicine, I would say. And over time, I would like to think I've gotten better at this because it takes a lot of practice. And it's one thing to come out of residency and training and just know what you need to do. You need to get the middle schoolers immunized with these vaccines. Like, that's kind of your focus. So it's kind of a fact base. Whereas I think as you gain more experience and time and relationships with families, it becomes a more collaborative conversation that you're able to sit down. There's a relationship there. There's a comfort level there that you can just have a non-confrontational conversation about, this is what this is. I appreciate that we are not allowing your child to be promiscuous by giving her this vaccine or him. That is certainly not the goal of this. So being able to have that conversation really helps. The next step, so collaboration, evocation, that is leading families and parents to draw their own conclusions so that they actually feel comfortable with having made this decision, whether to, or hopefully not, but not to give that vaccine, or at least to think about it for the next time. I mean, we have a window there, which is nice. And I will say I do use that, it becomes 3 vaccines after you turn 15, little line sometimes too, to kind of motivate people to think, okay, you're 14, I can only offer you the 2 doses for a little bit longer. And then the autonomy to just say, I will still support and see you and care for you and your children, whether you decide to do this or not, but you know where I stand. And I would hope that would be a mutually respectful, continued relationship in the future. And then offering more information if they need it, and reliable websites. I really find that is the other thing, that folks can find such unreliable sources digitally, that it's important to offer them the reliable ones. So this is the Virginia Department of Health Cancer Prevention. I think all of us being here on this meeting here today demonstrate our commitment to cancer prevention, and the HPV is playing a very important and particular role in that. So certainly we are all great champions of this process. And so there's my contact information. I'll just say, I didn't put it in the slides there now, but the 2 sites that I really like to refer folks to are the AAP.org, American Academy of Pediatrics.org. They have a lovely parent section that really breaks down and talks about vaccines. And then the CDC.gov website. Of course, I know the Virginia Department of Health has wonderful resources too, but we really want to be pointing these folks into good evidence-based sources, because like I say, there's so many anecdotal sources that just so muddy the water and can really sabotage our efforts. So I know I'm a little early on my time here, but I thought I would leave definitely time for questions.
Absolutely. And thank you so much, Dr. Tuohy, for a very informative presentation.
Yeah.
We do have questions that are coming in. So
Great.
Yes, and we're going to go ahead and start tackling some of these and invite the rest of you to jot your questions into that chat box, and we'll be sure to get to those. Tracy, I definitely agree. 98% prevention against certain cancers should be a tagline, and actually it is within a lot of the different organizations that are represented. The work, of course, is how do we get that message to go outward? How do we help with making people touch fire to the fact that this has such an efficacy rate that's very strong? Tracy has a question for you, Dr. Tuohy. Sure. What are Massachusetts and DC doing that unfortunately Virginia is not, for them to have such high rates of vaccine administration?
Yeah, that's a really good question. I will tell you that the pediatricians up in Massachusetts have really been on the front end of educating, promoting, going to each AAP state to try to implement improvement in their HPV vaccination. I actually participated in a couple of those, but they're all coming from the Massachusetts folks. So I think they're just very attentive to that. As to DC, I'm not sure, but absolutely kudos to them. But I don't think, to my knowledge, I don't think that the HPV is mandated in DC. So because certainly if this vaccine is becoming more of a mandate versus an opt-out option, I think that would certainly improve vaccine rates too.
Absolutely. And one thing that continues to be surprising is that Virginia has a mandate. However, there's no legislation that really pushes that. So it's kind of like having skin in the game, but not really a weapon that will help with that. We do know Virginia has one of the most lucrative anti-vaccine organizations as well. So that makes it a bit of an uphill battle as well. Yes. So I do have something from Cynthia. There's new HPV Vaccination Now campaign that's launched from the U.S. Department of Health and Human Services. It actually happened today. While the campaign is targeted primarily for Mississippi, South Carolina, and Texas, there are resources that are available, and she also lists that. Also, to let you know, cancer.org is also where we keep a number of our information as well. So you can definitely use the American Cancer Society's website. We are a part of the National Roundtable for HPV. We work closely with CDC as well as AAP and a part of their national cohort. So great information being shared here. Let's see.
Yeah, that's really fantastic. Thank you.
Absolutely. The mandate is right. It's not really a mandate since there's there's really nothing.
But I wanted to bring it up too because there was a House bill that was passed, and we'd like to think that we still have a little bit more leverage than we did even before the summer. So
absolutely, yes. So here's a question. I know that you mentioned there's a bit of a breakdown when it comes to completion rates compared to initial administration of the vaccine. What do you do with your staff to educate them on really pushing that message to their patients about completion for the vaccine?
So, right. I mean, I think some of our lack of completion is we've lost patients in follow-up. But that can't be 100% of why we're not getting those in. I will say, this is another reason why when kids come in just for their routine flu vaccine, if they need an HPV and we have reviewed it ahead of time, so that doesn't make it a standing order. If one of us providers has reviewed it ahead of time, we will offer that to them as well. I think it's truly a matter of getting those folks back in a timely fashion. And instead of being lost to follow-up. Most of the time, the folks who've had the single vaccine, I can't even remember when they've refused that second or third dose. It's just, oh yeah, I forgot about that. And so now I'm just finally doing it at a much later time. So their data is kind of skewed.
Right. Starting all over again.
Yeah.
What more can we do as far as the Virginia HPV Immunization Task Force? We're kicking off, of course, the 2021s with the series. We're glad to talk about this with providers as well as others in the medical field that would like to help with spreading that message around HPV vaccinations. But are there any other ideas that you would recommend for us to possibly look as an opportunity to build and educate not only the community, but also the medical fields, maybe something like office managers or nurses, anything else that we can do to really help spread the word?
Well, I think it does take a village to achieve what we're trying to achieve. All immunization efforts do take a strong collaboration with many different folks. Excuse me. I think also perhaps, just making sure the schools are playing a good role in this too, because they're seeing folks and families in probably a non-confrontational manner and just saying, hey, yes, you have to have your tetanus to walk through my door, but you should really think about the meningitis and the HPV as well to get here, because these are also very good preventive type things. But I do think from the point of coming into the office, when the child asks, do I need vaccines, to the receptionist, all the way through the end till when we complete the visit, to being consistent and saying, yes, there is a vaccination required. Yeah, there is a vaccination required that needs to happen. And just being positive throughout that whole process.
Wonderful, thank you. So another question around oral health, really trying to see if there is a way that maybe we can start to bridge those gaps. There's a lot of interest that's been coming lately through oral health, especially the dental industry, that's being able to see a lot of indicators of HPV through their patients. Of course, dentists are not able to administer vaccines, but do you know of any work that's being developed or being researched as of now to maybe start working together collaboratively around the oral health industry, educating their patients to refer them for vaccines?
I certainly know with my pediatric dental associates that they are very adamant and committed to promote that. Of course, they see the younger kids who are probably graduating out of their practice just as they're coming into, the time frame to receive the HPV vaccine. I mean, there are some folks who will stay all the way till, through high school with the pediatric dentist, but many will graduate to an adult dentist much sooner than they leave me. But yes, I mean, I would say definitely from that pediatric dental standpoint, they are promoting this as a good opportunity to help for future issues. And especially now with this new formal recommendation, I would say I have even had more conversation with the ENTs, of course, because they see the back end of these repercussions of having had the virus and the cancerous outcomes, that they are absolutely pushing that. And if folks haven't had it, if it's an adult or a child, either one, they're referring them back to consider to get those vaccines too. So again, the village approach.
Yes.
Mm-hmm. That's a good point. That's a good point. I mean, getting as many people on board as possible. I think that's excellent to have a little bit more formal recommendation from the dentist, because there's such an effect in that area.
Wonderful. We have been very grateful to have members of the Virginia Dental Association come on board. We have done for the last 2 years work with specifically the School of Dentistry at VCU, and worked on an HPV symposium, not only to introduce HPV to all of the oral health industry and those dentists, dental hygienists, those frontline folks, but also working on implementation. What are those formal discussions that they are able to have, as you mentioned? So I think there's a lot of promise coming through, and we're looking forward to seeing exactly what happens in the future. Thank you so much, Dr. Tuohy. This was a wonderful presentation. You are getting praises that are coming through.
Thanks.
Absolutely.
And I like that last one from you, Tracy, too, saying that, the kids listen to other kids. That's right. I mean, and that's sometimes another little one-liner that I'll say, you're not alone. All the other kids in middle school are getting these same vaccines, so they can commiserate together. Misery loves company, so there you go.
Very true. True indeed. Thank you all so much. Just something to call to your attention. Please feel free to sign up for our next peer-to-peer lecture series, which will be on Wednesday, February 3rd at 12 p.m. Again, thank you so much for being our wonderful speaker, kicking off the new year and reviving many of us and getting us going when it comes to patient outreach education. Thank you all for being with us today. I'm going to give you some time back in your afternoon. Thanks again and have a wonderful day. Bye all.